During the past 6 months, I've been privileged to visit many areas of our state to talk to and to listen to physicians. I've spoken with physicians who have years of experience under their belts and with young physicians who are just getting started. I've spoken to physicians in very large systems and with those in very small practices and many variations in between. Whatever their situation, they're acutely aware that we're living through an extraordinary time of change in our healthcare system. Of course, there's always been change, but this time it's different. It's bigger, it's broader, and it's more challenging than anything we've seen before. At the highest levels, we're seeing large hospital systems coming together at astonishing speed. There's a partial list of these on the screen. This list includes only the full organizational mergers. It doesn't show any of the service line clinical affiliations, which are often precursors to mergers. But those aren't the only changes we're seeing. In offices everywhere, we're seeing physicians employing teams of clinical and non-clinical personnel to deal with the new workflow. Many practices in large systems have deployed collaborative teams, which include PAs, nurse practitioners, and other clinical professionals. A decade ago, this scenario would have been rare, maybe even unthinkable, but it's here nonetheless. We're also seeing small practices starting to use electronic medical records. One of our recent surveys found that more than 2/3 of physicians are using some form of electronic medical record. If you think back to some of our health debates a decade ago, you'd say that this outcome would not have been predicted. Despite this adoption rate, most systems are not interoperable, making it difficult to link to other practices and systems to improve quality and efficiency. The more organized physician groups are taking on some degree of financial risk, although they're not going all in with both upside and downside risk. No one is at this point. Our future financial health depends on achieving a defined set of quality goals and being rewarded for it. Quality metrics and cost control capture the essential need for all of these changes. It will be difficult for a healthcare organization to remain viable if it is paid solely on the basis of volume. Even in a fee-for-service setting, physicians, hospitals, and providers in a clinically integrated system must demonstrate value. That means measuring quality and efficiency, the quality and efficiency of the care they provide. They must record it, measure it, report it, and further analyze it to improve for the next iteration. That's what true clinical integration is about. A new Medicare model is emerging. If it passes Congress, it would establish precisely this type of framework. Those who cannot record, measure, report, and analyze their efficiency and quality will find it difficult to be viable in the new reimbursement model in the Medicare system. That is particularly true of small practices. The federal definition at this point is 10 or fewer full-time equivalents. Massachusetts 224 looks at about 15. It's no mystery that this is the future of healthcare and that it's linked to the model that emerges from Congress. It is virtually on our doorsteps at this point. The biggest players in our system are in the best position to meet this challenge. That's not news to anyone here. They have the capital, the infrastructure, and the market share to begin to meet these requirements, making it possible for them to weather the transition period between the old and the new. It provides them with a built-in advantage, but even the largest systems wonder whether they can successfully deliver everything that's expected of them in the new order. So if they're worried, where does that leave everyone else? Not only the small practices, but the vast middle ground of mid-sized practices and groups that are doing the best they can to invest and innovate, all trying to do the best for their patients and their practices. They're trying to figure out where they stand. Usually that means figuring out how to interact with the largest hospital in their area. As I traveled around the state, speaking with physicians, I've seen a common phenomenon. The major hospital in the community is tightly aligned with a number of physician practice groups, working their way towards a clinical and financial integration, as well as a new contracting organization, or ACO. At present, most of these hospitals are also maintaining relationships with groups in their area that are still somewhat independent, but that utilize that facility. It remains to be seen if these hospitals will allow this mixed medical staff model to continue, or whether they will use their market power to try to bring everyone under their umbrella as employees to play by their rules. Strong medical staff bylaws are critical in this situation. Will the entire community benefit from an integration of all the practices, both employed and affiliated in the region, or will a tightly controlled hospital-employed physician organization dominate the scene? This is where the Department of Justice and the Federal Trade Commission come in, as we wonder how the federal and state governments will view these actions. As the big players are moving their pieces around the board, seeking the best competitive advantage, you can't blame the small players if they feel powerless to change things. That's why many of them are concluding that their best move is to join a larger organization, to line up with the biggest pieces on the board. Is that the right decision for everyone? Not necessarily. I believe that if a physician practice wants to maintain a meaningful degree of professional autonomy, they should be able to do so, while still meeting the imperative to deliver outstanding quality at a reasonable cost. Small practices must become part of a bigger entity, but that is not necessarily owned by a hospital network. They will need help. They cannot do it on their own. From the beginning of this payment reform discussion, back when Alice Coombs served on the Payment Reform Commission nearly 5 years ago, we repeatedly said that one size doesn't fit all. I still believe that today, and I believe it more than ever before. We want to help the small and mid-sized practice that wants to provide a personalized experience for its patients. We need to help the IPA that's been reliably going about its business for years, delivering tangible value for its members day in and day out. We must help the physician nearing retirement who is trying to decide whether it makes sense to make the necessary investments to stay relevant and viable. When we talk to physicians throughout the state, we very clearly tell them that becoming employed by a large system is not for everyone. In fact, it's not even necessary. It's possible to achieve a high degree of alignment and to be relevant in this evolving healthcare system without surrendering your professional autonomy. There are many points in the spectrum, from complete independence to full employment. Each point has its strengths and weaknesses. It is not necessary, but it can be done. It's not necessarily easy, but it can be done. We're trying to help physicians understand and explore the many different kinds of clinical integration that could occur and to help them decide what's right for them. The regional outreach meetings gave physicians the opportunity to speak frankly with each other about what they're facing and with other physicians who are dealing with the same issues. We published a comprehensive guide that has been one of the most popular documents ever published on our website. Also, we have hosted several live and recorded webinars in various aspects of these issues, such as a primer on data analytics that we held a few weeks ago. We're planning to do more of these opportunities for the coming months. Frankly, we will need to do this kind of work for many years to come. Will it help? I'm confident that it will. We will also work hard on the advocacy front to ensure that the rules of the game give everyone the opportunity to be successful, to ensure that we're not all stuffed into a single model that cannot possibly work for everyone. The public wants us to be responsible stewards of their healthcare dollar, but they also trust us to protect them against overzealous cost-cutting so that they can get the care that they need at the best place at the right time. We can do all of this. We can achieve these goals, but we cannot get there by trying to turn back the clock. If we try to, we would be destined to lose. But we can get there by helping physicians learn how to work differently in innovative, well-organized systems. We can help each other get there by developing the tools to deliver higher quality care at an affordable cost while sharing with each other what works well and what doesn't work as well as we had hoped. That's what we can do as a society of physicians and as a medical society. This cannot be a winner-take-all game. We need many winners for the sake of our patients and our profession. Let us use our discussions this weekend to reaffirm our vision for our colleagues, our patients, and our communities. As a postscript, we have a diversified workforce of MDs, DO, women, and men. And I state this because I think our focus is now on disease prevention and chronic wellness, but there's a lyric in a Young Rascals song that goes like this. Doctor, doctor, Mr. MD, can you tell me what's ailing me? That's our primary focus. Thank you very much.